Welcome everyone. This is the DNA Testing in Practice 10-module professional development program, and we are going to focus on the case study for Module 5. For this case study, we're going to be focusing on hormone metabolism, in particular in relation to hormone replacement therapy and what genes may influence someone's decision to consider hormone replacement therapy or the addition of hormones to help them deal with menopausal symptoms. So usually as practitioners, particularly in this area, we are trying to bring together a lot of information, often a lot of testing and quite complex cases. However, this case is a little different. It's fairly straightforward. The woman is relatively healthy. Really, her issues are around menopausal symptoms, and she just wants to understand a little bit more about her genes and predispositions or susceptibilities around estrogen metabolism, in particular with breast cancer, because her sister actually developed breast cancer. So this woman is 54 years old. She's concerned about menopause and how she's dealing with menopause. She's having trouble sleeping approximately 3 nights a week. She's having frequent hot flushes, and she's considering HRT or hormone replacement therapy. Looking at her signs and symptoms in relation to her reproductive history and what's going on right now, as I mentioned, there's the hot flushing. Previously, when she was menstruating, she was having heavy, painful periods. These would generally last for about 10 days and, as I said, are quite painful, so suggesting some hormonal imbalance perhaps in those previous years. She's had 2 children and only 2 pregnancies, so both of those pregnancies resulted in normal, healthy children. In relation to her gut, she reports normal bowel function and no known food sensitivities. With cardiovascular risk factors, she's previously had high blood pressure. It's relatively under control now, a little high, around 130 on 85. And with the other signs and symptoms, her BMI is 25. She's actually quite tall. She's slim, but she's actually gaining weight around her middle. And when we went through her questionnaire and her issues, they were more so focused on the sleep and the hot flushes. But when speaking with her, I think the weight actually was a very, very crucial issue for her that was making her consider HRT. So she was gaining weight around the middle. She reports feeling well most of the time. So this is a little bit different to most of our patients who come in quite unwell. She generally feels well. It's just these menopausal symptoms and this weight gain around the middle that's really an issue for her. She also reports feeling tired, but this is directly related to when her sleep is interrupted, when she's waking up in the night. So following on, some more information in regards to her lifestyle and her history. With her family history, her sister had breast cancer. And this has made her consider whether HRT is right for her because she is aware that there may be an increased risk for breast cancer and other related cancers. She has a history of hypertension and cardiovascular disease. And in addition, she's had a number of surgeries. So she's not on any medications, but in 1995, she had a tubal ligation. In 2000, she had a hysterectomy. In 2016, she's had a breast reduction. And in 2017, she had a bowel prolapse, which resulted in her getting a pelvic and bladder sling. With her diet, she has approximately 3 glasses of water each day, but she also drinks tea and 1 coffee. She has soy milk with her tea and coffee because she's lactose intolerant. We also know that soy contains phytoestrogen, so keep that in mind. She has minimal fast food, a moderate amount of fruit, vegetables and meats. I put in moderate. It's hard to gauge these things, but around that sort of 1 to 2 pieces of fruit, multiple serves of veggies a day, and she does eat meat, so she's getting that lean protein daily. She does report some chocolate, and we went into detail about this because weight is obviously the issue, and once we really got into that, she probably was eating a bit more chocolate than she thought she was. So that is a potential issue as well. With her lifestyle, there's the sleep issues, which are directly related to the menopausal symptoms. She does walk regularly, around about 3 times a week. She's a very active person. She travels. She's been renovating her home. So she is an active, generally well person. She has some work-related stress. She has alcohol about 3 times a week, which is usually just 1 glass of wine on those occasions. and she currently takes or was taking a women's multivitamin. So the main concern for this patient really was around dealing with her symptoms and what she can do to try to combat these. And she was thinking about HRT, but wanted to make an informed decision. So she really wanted to gain as much knowledge as possible to help her decide if HRT was a good option for her. She also wanted to improve her sleep, reduce the hot flushes, and try to lose weight, particularly around the middle, and actually stop her gaining any more weight as well as the weight loss. So this particular patient really wanted to know about her genetic predispositions. So once we received her results, there were a number of things we really wanted to talk about, particularly in association with estrogen metabolism. So if you look over at the hormones, because that's really the focus for this patient, we can see that she has a heterozygous, so a plus minus, a minus plus for the CYP17A1. So that's what pushes the pregnenolone and progesterone over towards the androgens. Then there's a variation in that CYP19A1, the aromatase, so pushing these androgens down towards estrogen, and that's because this SNP makes that enzyme work a little faster. Then with CYP1B1, cytochrome P451B1, this is the enzyme that sort of pushes estrogen down that 4-hydroxy metabolism pathway. And it's the 4-hydroxy metabolites that are potentially more dangerous. And she has inherited SNPs. That means she is more likely to push estrogen down that pathway. In addition, not only is she likely to be making more of these 4 estrogen metabolites, her COMT is a plus. What this means is she's inherited the variant genotype, which is associated with slower COMT activity. COMT is the phase 2 enzyme. So remember, the cytochrome P450s are the phase 1 detox enzymes. So these are involved in sort of converting and synthesizing these particular hormones. And then COMT is involved in the clearing and the metabolism of estrogen. It does this by adding a methyl group onto these estrogen metabolites. The plus that you can see here is associated with slower enzyme activity. So she is potentially metabolizing these estrogens at a slower rate. In addition, remember that COMT requires magnesium and also B vitamins. So for that transfer of the methyl group, she needs to have adequate Bs to make those methyl groups. Also looking at the other phase 2 detox enzymes down on sort of the bottom right-hand corner of the slide, we can see she's also got SNPs in the N-acetyltransferases as well as the GSTP1. So the glutathione transferase P1 enzymes are actually located in tissues such as the breast, those that do have reactive metabolites that can potentially turn into quinones. And if you've forgotten about this, if you haven't looked at Module 5 for a little while, I am going to go back to that diagram and I'll explain these things. But estrogens can get converted into quinones. These can cause DNA damage and may actually increase risk for cancers. And it's the GSTP1 that's involved in getting rid of those quinones and helping detoxify these potentially dangerous compounds. And there's the COMT that I mentioned before. The other thing I want to mention, moving over to the antioxidants, we can see that she is heterozygous for superoxide dismutase. She's plus, so homozygous for the variant for glutathione peroxidase, and she's also plus, so homozygous for NQO1. So when it comes to cancers, we really want to be thinking about things like inflammation and oxidative stress. These are often drivers that are associated with cancer. And remember, this is one of her concerns is with the HRTs, her risk for cancer. I don't generally focus on cancers, but that's a particular question for this patient, so we're making it relevant for them. With NQO1, remember when someone is homozygous, there is virtually no enzyme activity. What NQO1 does is reduce these quinones back to a less harmful compound or substance. So NQO1 stands for quinone reductase, and it helps reduce these quinones so that they don't go down further along the pathway, causing DNA damage and potentially then cancers and other health complications. And again, I'll show you that diagram to help you remember the actions of these enzymes. There are other things that we pulled out from the genetics in relation to blood pressure. We know with HRT and giving hormones, it can increase things of, such as blood pressure and stroke. So she is plus plus for AGT and heterozygous for NOS. So genetically, there is some underlying predisposition for blood pressure. And also remember, she's got that family history and she's had issues with blood pressure in the past. So according to her, she was on medication and has come off that. She actually feels quite healthy at the moment. As I said, she's not overweight. She does have that visceral adiposity, but generally she's not overweight. She doesn't look overweight. She does hide that sort of midsection well. However, she does have the genes that are likely to increase her risk of hypertension, and she has that history. So we want to consider these factors when we're going to introduce something like HRT that may exacerbate these risks. Moving over to the right-hand side of the slide, we can see nutrients. There's a few SNPs within the vitamin D genes. We know that vitamin D is important for everyone, but particularly when we're working with menopausal women, we want to think about bone health and reducing risk of osteoporosis, so ensuring that these women have adequate vitamin D and calcium. There were a few SNPs in relation to vitamin B12, and again, we need to ensure that methylation, so thinking about the folate, B12, B6, B2, these B vitamins to support methylation to help break down and metabolize these potentially harmful estrogens. So possibly an increased risk for vitamin B12 or low levels of vitamin B12, so ensuring she has enough of that. Focusing on choline, she has inherited genetic variations within PEMT, phosphatidylethynolamine methyltransferase. This is what converts our ethanolamine into phosphatidylcholine. It also requires a methyl group, so it needs the B vitamins. So she has a slower PEMT, therefore she may have lower phosphatidylcholine, and being menopausal, remember her estrogen has come down, and estrogen is what regulates PEMT. So she may have lower phosphatidylcholine. She also has inherited the heterozygous genotypes for both BHMT and MTHFD1, again suggesting there may be an increased need for choline. The other thing to mention here are the SNPs in relation to methylation and higher homocysteine. She has the heterozygous for MTHFR677. That means she's inherited the CT genotype. This may increase her risk for higher homocysteine. But again, thinking about methylation for estrogen metabolism, it's not just about the homocysteine, it's about having enough of the methionine and the S-adenosyl methionine, that SAMe, to provide all those methyl groups. So potentially a little less of that 5-methyl, which is needed to support methylation. She's got the MTHFD1 1958 heterozygous SNP. I mentioned that in relation to choline as well. And in relation to converting her homocysteine to methionine, both the genes MTR and BHMT, there's a SNP there. So she may require a little more B12 or support in converting her homocysteine to methionine. Finally, CBS, cystathionine beta synthase, she's a plus. Remember with CBS, when we inherit the variant, in this case, it's actually associated with a slightly faster enzyme and faster enzyme activity. Often when we have the variants, it's usually a slower enzyme that results from that, or perhaps it's a receptor that doesn't function as well. In this case, it speeds up the enzyme, well, that's the association. By speeding up CBS, what that means is homocysteine is more likely to be pulled down that transsulfuration pathway. And in this case, I think that's a good thing for this patient because we want that homocysteine coming down and supporting the production of glutathione. Remember, there's that SNP in GSTP1, so ensuring adequate glutathione to support detoxification. If these estrogens are turning into these reactive metabolites and then quinones, we want to have the glutathione there to help to neutralise these particular reactive compounds. In addition, we discussed it in the methylation case study and in the modules. Remember, CBS is activated by SAMe, so this will be activated, this enzyme, once there is adequate SAMe and methylation is functioning as it should. And finally, the last thing I want to mention on this slide, in relation to FADS1, fatty acid desaturase 1, she's inherited a SNP there, so potentially that fatty acid desaturase enzyme is working a little slower, so thinking about her intake of omega-3s in relation to EPA, which then would be converted into DHA, And also too, when we think about menopause, even the omega-6s, there's some evidence, so it's quite mixed, around evening primrose oil and omega-6s actually benefiting menopausal symptoms in some women. So thinking about fads and the impact it has on both omega-6s and omega-3s in this particular case. In relation to PON1, she's inherited one normal and one variant, so she's heterozygous, that plus minus. You want to look at PON1 in relation to things like pesticides, herbicides. Some of these particular pesticides that are broken down by PON1 can be endocrine disruptors. I will talk about it in the recommendations, but really emphasising the importance to minimise exposure to these endocrine disruptors is important. And the other genes that I've got listed there are factor 2, which is prothrombin, and factor 5, factor 5 Leiden. She has inherited the wild type, so the normal genotype, which does not increase her risk for blood clotting and stroke. This is an excellent result, but also very important to take note of if someone is considering hormone replacement therapy, because we know that some hormones, particularly the estrogens, may increase risk of blood clotting and stroke. So if she did have a SNP within factor 2 or factor 5, that would be something that you would want to refer to her doctor and seriously consider whether it's worth having hormones such as HRT or estrogen because of the risk around clotting and potential strokes. So here I'm just showing you the results. This is taken from the hormone profile. So generally I work with the wellbeing bundle, but in this case I wanted to focus on the hormone profile for this patient. It does make it a little easier in clinic to go through the results with the patient when it's focused on the genes that directly influence hormone metabolism. What you can see here are the phase 1 related genes, the cytochrome P450s, as well as those phase 2 detoxification enzymes, including COMT and NQO1, as I mentioned when we went through the results. This image is just to remind you of that metabolic pathway. So at the top, we can see in blue, we've got our CYP17A1 and 19A1, really sort of pushing the progesterone and pregnenolone over to the androgens and then down to the estrogens. And then we can see in the bottom section, in that kind of yellow colour, the phase 2 genes. So you can see that COMT is really important for converting those metabolites into the methoxy form, and then these can be easily excreted and they are less damaging and less toxic than those metabolites. You can see there the cofactors for COMT, so magnesium and SAMe. And if you look at that red box there with the 4-OH, E1, E2, so these are the 4-hydroxy metabolites. That's in red to highlight that these are the most, or potentially the most dangerous, because these can form the quinones. Remember that all of the metabolites are reactive. It's not just the 4-hydroxy that's reactive and can potentially cause damage to cells. It's all of them. It's just the 4-hydroxy is likely to be the most reactive and it can form the quinones. And these quinones really can cause damage, in particular DNA damage, which we know is an underlying factor or cause of cancers. So those 4-hydroxy metabolites can come down to the quinones, as you can see in the diagram here. And it's the NQO1. You can see the NQO1 can bring those quinones back to the 4-hydroxy metabolites, and then hopefully that will be converted by COMT into that methoxy form, which can then be excreted. In addition, the other way the body can deal with these quinones is with the glutathione transferases, so the GSTP1 in those particular tissues such as the breast and the ovaries. So the GSTP1 is located outside the liver and can help deal with these particular metabolites. In addition, what I like about this diagram here is it highlights the importance of the gut and the other pathways. So we're focusing on genes that are involved in metabolizing estrogens that we know have SNPs that can increase or decrease enzyme activity to try to determine someone's inherited predispositions or susceptibility for certain estrogen metabolites, or if they're likely to have, say, higher levels of estrogens. But remember, there are other pathways as well. So sulfation is important, glucuronidation, and just having a healthy gut and also supporting the liver to help metabolize these hormones. So what was my summary based on her inherited genes? So, really, I was able to inform her that there was a predisposition or an increased susceptibility for higher 4-hydroxy metabolites, those estrogen metabolites. And this would be more so of an issue if she was low in B vitamins, because remember, it's COMT that is one of the ways that we metabolize and excrete these hormones. She already has a slower COMT. So, if she was low in magnesium or Bs, this could further impact on her ability to metabolize and break down these estrogens. In addition, she's likely to be less efficient at clearing reactive estrogen compounds. Here I'm talking about the quinones, and this is because of the NQO1 and those GSTP1 SNPs. And when I say less efficient, I'm comparing this to people that have the wild type or the normal genotypes. Based on these results, I advise caution regarding HRT. Obviously, she needs to see a specialist, but if she was to introduce synthetic hormones or HRT, it's likely that she's going to push these estrogens down that 4-hydroxy pathway, and then her ability to clear them is compromised due to the genes that she's inherited. So, what were my recommendations? Obviously, reducing exposure to endocrine disruptors was an important recommendation, and actually I discussed this with her even before she'd done the genetic testing. So in that initial consult, when she came in and said she wanted to have her genes tested, we discussed things like phthalates and parabens. Of course, there are other endocrine disruptors, but these are often the common ones found in plastics and skincare. She didn't really know about the plastics, had heard some things about skincare, and was shocked to find out about the parabens. So when I do talk to patients that actually have no idea about this, I tell them just to look for that. The paraben, it could be methyl, it could be ethyl, it could have, a number of different letters in front of the paraben, but look for that paraben at the end. And actually a number of her skincare products, shampoos, conditioners, moisturizers, things that she was putting on her face actually had parabens and other endocrine disruptors. I actually provided a link to the Australasian Menopause Society, and also for those of you who are talking about endocrine disruptors to your patients. If they have no knowledge of this and they're unsure, you can obviously refer them to sites such as the EPA, the WHO, or the NIH that actually talk about the evidence around endocrine disruptors in our environment and in everyday products. But in this case that's focused around menopause, there's actually a very good article on the Australasian Menopause Society, and I can add a link for you if you'd like to look at that. And it's a good one to actually give your patients because it talks about endocrine disruptors in relation to menopause and menopausal symptoms, so that imbalance in hormones that can be affecting the hot flushes, issues with sleep, mood, anxiety, things like that. So in this case, she didn't report any issues with mood, but we know that these endocrine disruptors and hormonal balance can have other effects in the body as well. And this particular site, it's well referenced. It also talks about a small study, but it's a randomized controlled trial looking at phthalates that are endocrine disruptors and showing that when women did remove plastics, just in a short amount of time, I think it's about 3 months, they did reduce their phthalates. And again, when it comes to testing, I generally look at a lot of endocrine disruptors and phthalates, particularly for my fertility patients. And when I do inform people of where these particular chemicals are found, when they remove them or try to reduce their exposure as much as possible, we do see them come down. In this case, I didn't think it was necessary to test because my advice around minimising endocrine disruptors is the same. With my fertility patients, sometimes we do want to identify if they do have endocrine disruptors, if this is the cause of perhaps their fertility issues, but also we want to see these things come down before they go on to conceive and have a baby, because we don't want these things being transferred to that growing fetus and the baby. But in this case, this particular lady was very motivated and I didn't need to do testing and show her the levels. She went away, looked at her products and changed some of these things that she was using and exposed to. When it came to diet, we know that weight loss, particularly in those menopausal years, can be really difficult. And I spoke to her about intermittent fasting, such as the 5-2 diet or even time-restricted eating to help with weight loss. There is quite a bit of evidence around this now. Intermittent fasting in relation to time-restricted eating, and what this means is eating between a certain window, perhaps skipping breakfast and then making sure that you're not eating past, say, 8 p.m. or having breakfast but having an early dinner and not eating later in the evening. There's quite a bit of research around that now in relation to weight loss and even reversing some autoimmune conditions, reducing inflammation, autoantibodies, things like that, type 1 diabetes, etc. This didn't work for her. She's very social. She likes to have dinners. She also enjoys her breakfast. However, the 5-2 was appealing and she has started that. She has seen a little bit of weight loss, not a lot yet, but the main thing is she's gaining weight because she was really gaining weight around the middle. And as someone who's never really been overweight, she's quite lean and tall. That was a big issue for her, as I mentioned at the beginning, and really came out the more that I spoke to her. So she's trialing the 5-2. When people initially start this, there's a lot of sort of 2 steps forward, 1 step back. They may not commit to that sort of 500. And now it used to be 500 calories on those 2 fasting days. Now they're saying up to 800 calories is fine. Some people end up eating more the day after, or they can't commit to the 2, but it takes a bit of time. And all I'm trying to emphasize here is stick with it, because people don't often nail it straight away. But once they do, it is easier to stick with once they've got in the habit. And it is associated with weight loss, particularly around the middle. And what she needed was something to sort of shake up her system. She had a relatively good diet. She was a little active. We're going to talk more about exercise, but really her diet wasn't her problem, aside from the chocolate. Remember, we did talk about the chocolate and actually eliminating that from the house, which was a difficult conversation to have. When it comes to exercise, there's no real evidence suggesting that exercise directly improves menopausal symptoms, things like the hot flushes, but we know that it can help prevent weight gain and even help with weight loss. It can improve sleep, particularly if it's earlier in the day, not exercising at night before bed, but those that exercise earlier in the day tend to sleep better. It strengthens the bones. Remember that osteoporosis and bone loss is an issue in menopausal women. It can help improve mood for those particular women who are struggling with, mood changes, anxiety and depression. Exercise can help there. And it can reduce the risk of chronic disease. And remember, when we're talking about things like hormone replacement therapy, which really is the emphasis of this particular case study, we know that there are risks for, cancers and stroke and things like that. And by exercising, you can actually minimize that risk. In addition, not that it's particularly in relation to menopause, but as someone who's approaching their mid-50s and getting older, we know that it can help prevent falls later in life, and that's a big issue. In this particular case, as I said, this woman is relatively lean, aside from what's around the middle. So lean that she actually has quite narrow hips, sort of more broader shoulders, but she doesn't have much of a backside. I'm getting a bit personal here. But, doing some strengthening exercises to strengthen the muscles in her legs and her glutes would actually be really good, in addition to helping with all of the menopausal symptoms, as I said, preventing falls later in life, which can be a big issue for older adults. Following on with my recommendations, specifically for this particular woman, the hot flashes were an issue. We know that phytoestrogens may actually help. However, there's mixed results. So phytoestrogens can help with some of these symptoms, but there are concerns around increasing risk of things like breast cancer, similar to hormone replacement therapy. I've actually added a link here to a really, really good paper that discusses the pros and cons around phytoestrogens. Phytoestrogens can be proliferative, so meaning sort of stimulating cell growth, like what estrogen does. So when we think about estrogen, what does it do? It actually helps proliferate and is involved in stimulating cell growth, particularly around, breasts, hips, and reproductive tissue and reproductive organs. So phytoestrogens are similar in that they do have that proliferative effect, but they can also be anti-proliferative. So they can actually be protective in some ways if we're thinking about cell growth and we're worried about tumours and things like breast cancer. In addition, if we're talking about phytoestrogens, often these phytoestrogens found in foods or herbs come with added benefits, such as providing nutrients, but also antioxidants. And this can help reduce inflammation and oxidative stress which may not be provided with particular synthetic hormones or HRT. So that's something to think about as well. And that may even explain some of the mixed results, because there are some results suggesting that the phytoestrogens have great benefits in reducing hot flashes and helping with menopausal symptoms, and then in some cases they don't. There are trials in relation to menopausal symptoms with black cohosh, so that's something that can be considered, and also reducing alcohol can help. Moving on to sleep, a lot of what I said here the patient already knew. She'd done quite a bit of reading before coming in to see me, but sleeping in a cool, dark room, having layered bed covers so that if women are getting hot during the evening and the night when they're trying to sleep, they can remove those. And good sleep habits, the things that we're always telling our patients: reduce screen time before bed, not having caffeine in the afternoon, and trying to set up regular times for going to bed and waking up. That has shown to help with improved sleep quality. And as I mentioned in the previous slide, exercise can actually help with sleep quality as well. In addition, we want to ensure there are no nutrient deficiencies. This can help support, assuming there is adequate nutrition, proper hormone metabolism. For example, thinking about magnesium and the B vitamins to support COMT. I mentioned that she was on a women's multi. What I did do is swap that women's multi to one that actually had higher and more kind of natural forms of the B vitamins to help support methylation and COMT. And I also added in an extra magnesium supplement. So for this particular patient, it's important that she continues to work with her GP. So she had a GP that was very invested in her health. It was a young male doctor who didn't actually have a lot of experience with menopause, but he had done a lot of testing, had reached out to colleagues in relation to HRT, which is her question, and because of her family history with breast cancer. I also advise following up with a naturopath or a herbalist to discuss herbal remedies. So I talked about the phytoestrogens and black cohosh. There's actually a lot that we can do using herbs and natural products, but it's something that I wanted her to follow up with an expert who specialises in menopause and prescribing these particular herbs. Based on the genes, you can see that there are those predispositions. And it's likely that, I would think HRT is not the best option for her. However, she needs to still speak with a specialist and she needs to make that decision herself. It all comes down to how well she can manage these symptoms and how well she can get through her daily activities. Her issues were the weight, the sleep, and the hot flashes. But really her day-to-day life, I didn't think, as the practitioner sitting in with her, was compromised to the extreme that I have seen with some other people. She was able to work, she was able to travel. So I think these more natural things like exercise, diet with the weight loss, bringing in supplements would be the best option for her. And then, as I said, bringing in a naturopath or herbalist to help her with some of these herbal remedies that may be able to help her deal with those hot flashes and improve her sleep. But again, really this was about providing her with the education and the knowledge to help her go away and make that particular decision herself. She was an educated woman who'd done a lot of reading and really was just gathering the evidence. So this was a relatively easy case study for me. It's not often you come in and see someone who is relatively well. Generally, the cases are much more complex, but I wanted to show you how the genes can actually help you make these decisions or help inform your patients make decisions around things like hormone replacement therapy or even the contraceptive pill, because they can start to understand how their body will metabolize these particular hormones.